Um, I've listed my website on this first slide for you to reference if you're interested at all in a couple of books I've written. One's called The Curious Man's Guide to Urology, and the other is called A Curious Woman's Guide to Urology. There's no specific chapter on pediatrics, but in the man's book, there's a chapter on circumcision. I think it's called Mysteries of the Foreskin. And in the women's book, both books, there's a chapter on UTIs, which I talk about children quite a bit. So this is an outdated disclosure. MAVEN is now doing their own CME. This was the only slide I had. So Kristen hopefully will update this slide for the disclosure for CME. So let's get right into it because there's a lot to talk about. Congenital urologic urogenital abnormalities comprise probably about 80% of what pediatric urologists do. And full disclosure, I am not a pediatric urologist. I am not fellowship trained because in 1982, when I finished my residency, the people that were doing fellowships in specifically pediatric urology were people that wanted to work in academia. And I wanted to work at Kaiser, where I would get the full range of urology, including cancer of the urogenital organs and stones, which is what I specialized in. But I did pediatric urology for 25 years while at Kaiser until we hired a fellowship-trained pediatric urologist. So I have quite a bit of experience doing pediatric urology and a lot of interest. In fact, I went into urology primarily because I wanted to help children. I originally wanted to be a pediatric surgeon, and then it's a long story, but I got sidetracked into urology from general surgery. So what are we talking about today? We're talking about abnormalities of the kidney, ureter, bladder, genital disorders of different sexual differentiation, which are usually diagnosed in utero, but sometimes during infancy and sometimes as late as childhood. So when we're talking about something like hydronephrosis, most hydronephrosis is diagnosed in utero, whereas some disorders, for example, testicular feminization, isn't diagnosed frequently until later in childhood. So I hope there are no questions about the anatomy, so we can just go on. The next slide, if I can. Uh-oh, there it goes. Okay, so we'll talk first about urinary anomalies, and then we'll talk about genital anomalies. The urinary anomalies are a bit easier to understand and are far more common. The genital anomalies are more difficult to understand and are less common. So hydronephrosis would be the most common thing that you'll see in a fetus or newborn. It's either due to obstruction or no obstruction in the case of vesicoureteral reflux. There are duplication anomalies of the kidneys and ureters, or both. There are rare kidney anomalies such as horseshoe kidney, ectopic kidneys, crossed fused renal ectopia, multicystic dysplastic kidney. And then there is a thing called posterior urethral valves, which I'm going to talk about in just a second. There are non-urologic anomalies that result in urologic problems, such as spina bifida meningomyosial, which results in a neurogenic bladder. There's a rare anomaly called a bladder exstrophy, which is where the baby is born and the entire bladder lining is exposed on the abdomen, and it requires immediate repair. When I was in practice, I saw 2 bladder exstrophies, and I fixed both of them with a pediatric urologist from Oregon Health Sciences University. Prune belly syndrome is another rare anomaly, which I have not seen since I was a 4th-year medical student at Children's Hospital of Los Angeles. Genital anomalies include such things as hypospadias, undescended testes, disorders of sexual development, intersex, ambiguous genitalia, hermaphroditism, and pseudohermaphroditism. So embryology is something that a lot of people find difficult. I found it difficult. It's complicated, and it would require an entire hour for me to talk about the embryology of the urinary tract. So I've listed a couple of websites that I actually searched and read, and these are the ones that I think are can be helpful if you are interested in further um, further study of the embryology of the urinary tract. Um, I always found it complicated in medical school and hard to understand. And even during residency, when I had to learn it, I found it difficult. And I really didn't understand it until I went to take my oral boards. In urology, you finish 5 years of residency and then uh, take a written board examination. And then in order to become board certified, 2 years, you have to be in practice for 2 years. And at the time that I was studying for my boards, oral boards in 1984, I'd been practice for 2 years at Kaiser in Portland. And we had to all take a review course at the AFIP, which is the Academy of uh, something pathology in Washington, D.C. It's a major organization. We had to take a review course in for a week. It was a week-long thing, and all the candidates for the oral boards attended. If you didn't attend, you didn't pass. And in the morning, they would talk about uh, radiology or pathology. In the afternoon, you reviewed pathology slides. And one of the lectures during that week-long course was a guy named C. Everett Koop, who is a plastic, or he's a pediatric surgeon at Children's Hospital of Philadelphia. He was. He was also the Surgeon General at the time. And Dr. Koop came and gave an hour-long lecture on GU embryology, which was absolutely fantastic. So that's how I sort of got interested in this. Anyway, so hydronephrosis. Hydronephrosis, you see on the left slide. I don't have a cursor, so I can't show you. Um, Hydronephrosis is diagnosed frequently in utero, and this is what it looks like on an IVP, which is no longer done. The diagnosis is made by fetal ultrasound, and it's either due to obstruction anywhere along the urinary tract from the ureter-pelvic junction or proximal ureter all the way down to the distal ureter, or even the level of the prostate in boys, which is what posterior urethral valves is. So if it's not due to obstruction, it's due to reflux. And this is a picture where I purposely cut off the ureter so you can't tell whether or not it's from reflux or distal ureteral obstruction. The ureters are dilated in this photograph of an IVP. So it could be distal ureter at the end of the ureter where the ureter enters the bladder, or it could be from reflux. And this would be grade 4 reflux. Reflux is graded depending on which system you use, 1 through 4 or 1 through 5. So if you have a baby with hydronephrosis, you have to assess whether it's mild, moderate, or severe, and whether or not it's obstructive or from reflux. Then you have to decide if it's fixed or permanent or whether it's transient. So many cases of mild hydronephrosis are transient and will resolve. So what do? Well, check a urine, check a BUN and creatinine, and you do serial ultrasounds if you think it's going to be transient and get better. If it doesn't get worse and the infant remains uninfected, or if the kidney function is stable, you can follow them. If it does get worse, you'll need to do a VCUG or refer to a pediatric urologist to order the VCUG. And if there's no reflux on the VCUG, then we do what's called a MAG-3 nuclear medicine scan. And that will determine whether or not the kidney is obstructed. In moderate to severe hydronephrosis in a newborn fetus, is it unilateral or bilateral? If it's bilateral, it may be due to reflux, but unilateral hydronephrosis can also be due to reflux if one ureter is refluxing and the other one is not. You check the renal function and do a urine analysis to figure out if the kid's infected, or if the kid's infected and then you find that there's hydronephrosis. Then you have to do a VCUG to see if there's reflux. A VCUG will also help you make the diagnosis of posterior urethral valves. If there's no reflux, then we do the MAG3 renal scan with Lasix washout. So older children, it's not just babies that present with hydronephrosis. It can be older children. They present with back pain, nausea, vomiting, hematuria, vague abdominal pain, or febrile urinary tract infections. Common causes of a UPJ obstruction, which is what you see on the left side of this slide in the left kidney, would be a scar or fibrosis or a vessel that is crossing. And that's not shown in this picture. You can get two renal arteries, and one of the renal arteries can ascend from the, or can take off from the aorta proximal to where the left renal artery is feeding the kidney on this picture. And the renal pelvis will be draped over that secondary renal artery, renal vessel. There are uncommon causes of UPJ obstruction. That would be stones or polyps. I've never seen one in a kid, but it's certainly stones are certainly a cause of hydronephrosis in adults. The diagnosis, again, is made by ultrasound VCUG, MAG3 nuclear medicine scan, and nowadays we do MRIs instead of CT scans because of the radiation. Treatment of a UPJ obstruction is by a procedure called a pyeloplasty, which can be done open, laparoscopic, or laparoscopic robotic assisted. So posterior urethral valves are, it's a membrane that develops in the prostatic urethra that causes obstruction of urine during voiding, and it results in a hypertrophied bladder and a dilated prostatic urethra. Can present with bilateral hydroureteronephrosis in a newborn or a child who has difficulty urinating. It'd be more common, the more common presentation would be in a newborn. It can present as an abdominal mass, a urinary tract infection, poor stream, urinary retention, and impaired renal function. Duplication anomalies occur, and it has to do with how the kidney and ureter are formed in utero. You have a takeoff of a ureteral bud from the bladder in utero, and the ureteral bud implants into the metanephros, and that's what causes the development of the kidney. The kidney then ascends in the fetus. So if you get two ureteral buds coming off the bladder, then you get two ureters, or the single ureteral bud can divide in utero, in which case you'll get two ureters. And what happens is you get two collecting systems into one kidney, or there can be two kidneys if each kidney develops separately. This is an example of what's called a duplication anomaly with an obstructing ureterocoel. Ureterocoels can be either single, or they can be involved in a duplicated system. And when a ureterocoel is present in a duplicated system, it's always in the lower pole moiety of the kidney, and the upper moiety will reflux. So that's just for your benefit. In a ureterocoel that's to a single ureter and single kidney, the treatment is transurethral with incision of the ureterocoel to allow it to drain. Ureterocoel is this big, it looks like a size of a dime and it has a little pinpoint opening at the end of it. That's why it's obstructed and forms the ureterocele. These are pretty common. I saw a fair number of these in practice. Um, Horseshoe kidney is when the two ureters implant into a single moiety, and the uh, ascending kidney, as the kidney ascends toward their uh, place of residence in the flank, they start down in the pelvis and they ascend in utero, and they get stuck on the inferior mesenteric artery, which you can see in this photograph. If you look at the aorta, the first branch off the aorta is the celiac plexus. The second branch is the superior mesenteric artery. And the third, which you can see, the inferior mesenteric artery feeds the bowel. And the kidney, as it ascends, gets stuck. And it's a solitary kidney, and it looks like a horseshoe. Um, an interesting thing that I did when I was a resident was I was called to do a kidney retrieval for transplant on a patient who had been in a motorcycle accident and was pronounced brain dead and was a kidney donor. And my boss and I went to the hospital and we did a retrieval, and we separated the horseshoe kidney and took each uh, right and left side and used them for two transplants. This is an example of cross-fused renal ectopia, which is the left kidney in this case has migrated over to the right side and is fused with the right kidney, the lower pole of the right kidney. Another thing that can occur is a multicystic dysplastic kidney, which is not uncommon. I've seen several of these, and what happens is that the ureteral bud doesn't fuse with the metanephros, and so the kidney never develops. And this is what it looks like. This is a cartoon of that. It's usually unilateral. It rarely is bilateral. If it is bilateral, it's not associated with life. Um, when it's unilateral, it's generally not a big deal. The multicystic dysplastic kidney involutes over time, and you won't even be able to see it on ultrasound. This is what it would look like on ultrasound, just a bag of cysts in a newborn. Rarely is it associated with UTI or hypertension, although one of the things that you follow in children with a multicystic dysplastic kidney is hypertension. It's not associated with an increased incidence of Wilms tumor, which is the most common renal tumor in children, most commonly seen in children ages 3 to 4. Wilms tumor is not common. In my entire practice, I saw 4 Wilms tumors. And interestingly enough, I saw 3 of them in 1 month in, I believe it was 1985 or 1986. And I was fortunate enough to be able to remove all 3 of them. The fourth one was a more complicated situation in a bilateral Wilms tumor. And that child was treated up at the university, OHSU in Portland. Just a little side note. This is different from polycystic dysplastic kidney, where there's actual kidney parenchyma in between the cysts. You can see polycystic dysplastic kidneys in children. It's again very rare, more common in adults. Okay, before we go on, I really didn't talk about vesicoureteral reflux very much, aside to say that it's graded on a scale of 1 to 4, 1 to 5. And treatment used to be bilateral reimplantation when it didn't go away. A lot of grade 1 and 2 reflux children will resolve. Many of them need to be on antibiotic suppression to prevent recurrent urinary tract infections, which prevents further damage to the refluxing kidney. But some of them do resolve. When surgery is indicated, it can be done transurethral by implanting some material underneath the floor of the ureteral orifice. It's called a sting procedure, and it's very common and very easy, and is very efficacious. So let's talk about this now, disorders of sexual development, which includes the problems of intersex, ambiguous genitalia, and hermaphroditism. This is a little more difficult for me and probably for you. It's a group of conditions in which there's a discrepancy between the appearance of the external genitalia and the internal genitals, whether they be undescended testes or ovaries, or whether the testes are descended and palpable and the internal organs can be like a uterus. So ambiguous genitalia are kids that have, you can't tell whether they're male or female, and that is a medical emergency. Hermaphroditism is a person or an organism, whether it be human or not, that has both female and male sexual genitalia. In certain non-human plants and animals, hermaphroditism is the common way that they exist. In certain plants, it's normal. Pseudohermaphroditism is when an individual has one sex of external genitalia superficially resembling those of the other sex. For example, a very highly virile, I'll talk about this in a minute, but a highly virilized female will look like a male with hypospadias. When a child is born with ambiguous genitalia, like I said, it's a medical emergency. In many hospitals, children's hospitals, pediatric hospitals, there is a multidisciplinary team consisting of an endocrinologist, pediatric endocrinologist, a urologist or pediatric surgeon, a mental health worker, either a psychiatrist, pediatric psychiatrist, social worker, or psychologist, a geneticist, a gynecologist, and a neonatologist. The team will then be tasked with assigning how the child is going to be reared, or the sexual identification of that child. The child can present with a very small penis or what could be regarded as an enlarged clitoris. Sometimes you can't tell the difference. There can be partial fusion of the labia. There can be cryptorchidism, in which you cannot feel any testes in the groin, and are the testes in the abdomen, and are they really testes, or are they ovaries? They can be ovaries in a child that looks like a boy. If the testes are labial or present as an inguinal mass, could they be testes in a genotypically X girl? Severe hypospadias is another indication of intersex or disorders of sexual development. And all these things usually appear in the genitalia at birth, but can sometimes be delayed if somebody doesn't make the diagnosis appropriately. Say you have a child who has penoscrotal hypospadias. Well, that's a intersex problem, but sometimes it's just written off as severe hypospadias. I've seen both. In a girl that has delayed puberty, or a boy that has delayed puberty, you have to suspect some sort of intersex problem, or consider some sort of intersex problem. So what do? You get a karyotype. You do some measurements of hormones, usually testosterone and other female hormones. You can do hormone stimulation tests. The endocrinologist will usually do this. Check the electrolytes for congenital adrenal hyperplasia. You can do molecular testing. The gynecologist will sometimes do endoscopy, or the urologist will do endoscopy through a hypospadiac external urethral meatus, which can be on the penis scrotum or even on the perineum. And you want to know whether there's a cervix present or if there's a vagina present. You can do ultrasound or MRI to see if there's a uterus or impalpable gonads in the abdomen. Causes of disorders of disorders of sexual development. It can be a child with XX, 46XX, and intersex, a child with 46XY and intersex. There can be true gonadal intersex in which the gonads are both XY and XX, or there can be a complex and undetermined intersex diagnoses. And these are things that drive a pediatric urologist crazy. So what's XX intersex? The chromosomes are female, gonads are ovaries, but the external genitalia appear to be male. Why does this happen? Well, it happens because there's an increased amount of male hormone in the mother. And it results in fused labia and enlarged clitoris. For all the world, the kid looks like a boy, but is not. It's a girl. The uterus is normal, and there will be normal fallopian tubes. And this is what's called a pseudohermaphrodite. One of the common causes is congenital adrenal hyperplasia, and that results in an increased amount of male steroids in the fetus. The mother can consume testosterone for whatever reason, or testosterone-like substance. There can be an ovarian tumor in the mother that produces testosterone. And then an aromatase deficiency is a problem of the adrenal glands in which testosterone is not converted to estrogen. So this is, I think it can be either in the mother or the fetus. I'm not quite sure about this one. I'd have to look that up again. I should have. Sorry. XY intersex. Chromosomes are male, but the external genitalia appear female or ambiguous. In the case of severe hypospadias with impalpable, that should be impalpable, not implacable, impalpable gonads. The testes can be present and normal, and the internal organs can be malformed or absent. In other words, not a normal prostate, not a normal seminal vesicles. The child will be under-virilized, in which case that defines male pseudohermaphroditism. The causes, again, can be a type of congenital adrenal hyperplasia or gonadal dysgenesis, agenesis, or some type of testosterone production failure. 5-alpha reductase deficiency is another cause. What 5-alpha reductase does, it converts testosterone to dihydrotestosterone. Okay, if you don't have any dihydrotestosterone, the male genitalia will not develop properly. Androgen insensitivity is another thing that happens, and that is when the gonads are not sensitive to normal estrogen levels. Okay, so you have a child that's XY intersex, but the gonads don't develop properly. They don't produce testosterone, or they do produce testosterone, but the sexual organs, the sexual development of the prostate and seminal vesicles, vas deferens, is not normal. And that would be the most common cause of 46XY intersex, and that is also known as testicular feminization. And these children are sometimes not diagnosed until they're older children or adolescents, and they for all the world they look like females. Their external genitalia are female genitalia, but they don't have ovaries, tubes, or a uterus, and they are 46XY. They're genetically males, but they look like females. And their testosterone and dihydrotestosterone is normal, but the hormone receptors are not normal. And these children are typically very good athletes, and I've seen a couple of them in practice. There's such a thing called true gonadal intersex, which is in the case of both testicular and ovarian tissue can be present. They can even be present in the same gonad, which is called an ovotestes. These children can have one testis and one ovary. They can be 46XY, 46XX, or both, and that's a true hermaphrodite. The underlying cause of this disorder is unknown, said to be linked to pesticides or other environmental toxins. There are other disorders of sexual development, including Turner syndrome and Klinefelter syndrome, 47XXX. They do not have a discrepancy between internal sex organs and external genitalia, but the sex hormone levels can be altered. There can be phenotypic abnormalities, disorders of sexual development, and fertility can be impaired, as in the case of Klinefelter's or Turner syndrome. You may not know this until the man tries to have children, or either of the man or woman tries to have children. There can be delayed puberty as well. Treatment. Complex on many, many levels. Again, multidisciplinary approach is necessary. There's a shift away from immediate assignment of sexual rearing and immediate surgery to more deliberate, measured, and thoughtful approach. But this is usually accomplished within the first month of life. It used to be that you assigned sex rearing immediately, and now it's more delayed and measured by the team, and I think that's probably a good idea. Each individual decision is dependent on the unique genotype or phenotype of the baby. It's not only that genitalia, gender assignment is important, but hormonal, psychological, neural, and behavioral factors need to be considered, which in one of my final thoughts is that all this political mess between politicians regarding transsexuals doesn't typically take into account their profound misunderstanding of these children and how they can be transsexuals. And it's assumed by politicians that the transsexualism is a mental or somehow acquired phenomena, but it's not. It's something that these children or adults are born with. And I really wish that politicians would stay out of our exam rooms. That's all of my political soapbox. So let's conclude with hypospadias and undescended testes. You all know that in a baby that's born with hypospadias, you're not supposed to circumcise them because we use the foreskin to recreate the urethra in a 46XY male baby with hypospadias. And usually that hypospadias is confined to the glans corona, distal penile urethra, or midshaft. Hypospadias occurs because the urethral tube doesn't finish its completion of formation as the fetus develops. Normally, the urethral tube, in response to male hormone levels in the fetus, will close from proximal to distal, so from scrotal to the tip of the glans. When it's proximal hypospadias, you should consider the disorders of sexual development. Midshaft to distal penile, coronal, and glandular, not so much. The repair and these repairs are technically demanding and requires some expertise and should be done in this day and age by a pediatric urologist, although I did many of them for 25 years. Basically, there are many, many ways of fixing hypospadias, and we all have our preferred ways of doing it. I'll just leave it at that. So we'll finish up with undescended testes or cryptorchidism. On the far left side, you can see true cryptorchidism versus ectopic undescended testes. And they, unless you can feel it, it really doesn't matter whether it's ectopic or true. They should probably be fixed. When you see a kid with an impalpable testes, you have to decide whether it's retractile ectopic or true undescended testes. Like I said, it doesn't matter whether it's true or undescended. If you can't feel it, then you should probably refer to a urologist. If it's retractile, one of the ways of, first of all, 30% of preemies are going to have undescended testes versus 3% of newborns. As a newborn gets older, the testes are usually down by 4 months where you can feel them. If you can't feel it by 4 months, it's time to refer. And we usually like fixing these before the child is a year old because you reduce the risk of cancer and infertility, though you don't eliminate it. So a kid that has a true undescended testis that's brought down by an orchidopexy still has an increased risk of cancer, but it's not as great as if they had an untreated undescended testes. So what's the soap trick? The soap trick is a way that urologists use to bring down a retractile undescended testis, a retractile testis that's either in the high scrotum opposite the pubic bone or in the groin itself. And what you do is you get your one hand real soapy and you get the groin real soapy and you just kind of massage from the iliac crest with the soap with a little bit of pressure along the inguinal canal to see if you can either feel the testis or get it to come down into the high scrotum where you can, with your other fingers, coax it down into the scrotum. If you can get it down into the scrotum where you can feel it, then it's a retractile testis. And most of these retractile testes will descend at puberty when the testis enlarges and gains weight and will descend. But sometimes they get stuck. So it's why we like to examine retractile testes on a yearly basis. If you have a kid who you can't feel the testis and want to know whether or not it's in the groin, don't do an ultrasound, it's unnecessary. A urologist will be able to tell whether the testis is in the groin or not. And if the urologist can't feel it, then we usually send them for an MRI to see what's going on and where it is in the abdomen. And that's all important in planning whether or not to do an operation to bring it down. And the surgery to bring down an intra-abdominal testis is, again, complicated and challenging. If the testes are not palpable, you need to refer that, do a karyotype and then refer that immediately. And I think I finished with 15 minutes to spare. So, any questions?
Thanks, Dr. Lieberman. Just a reminder, if you have any questions, you can put them into the Q&A box or use the raise hand feature and you can speak directly to Dr. Lieberman. I don't see any questions right now, which gives me the opportunity to ramble about the CME survey. Just a reminder that the survey is going to appear on a tab in your browser when you close out of the webinar. It will also be in the email tomorrow with the slide deck, which is going to be sent around this time tomorrow. And you can, as long as you have the correct date and time, name, so July 9th, Dr. Stephen Lieberman, you will receive that automatically. Question. Oh, I missed it. For babies that are diagnosed with
Nephrosis?
Yeah.
Yeah.
It's the big words, they always get me. In utero, how long after delivery should they have a renal ultrasound?
Depends on the degree of hydronephrosis. If it's mild hydronephrosis, I think you could probably wait a month. If it's moderate to severe hydronephrosis, I think you should do it immediately and then refer to a pediatric urologist.
Great.
Does that answer the question?
I think so.
Okay.
If not, please just put in the chat and we can continue talking about it.
That's a good question. Really good. For how many people are listening? I don't have any idea.
Yeah, so we have 19 logged in, but a lot of the groups meet in one room, so there'll be multiple. So I'll
Oh.
tell you the exact number later.
I feel like I'm talking to the ether.
Oh, well. Okay, we have a couple thank yous. Wonderful, excellent. Okay. We love positive feedback. Yeah,
No further questions?
I know.
My goodness.
When is it okay to refer to surgery if we can't get a urologist?
I'm sorry, repeat the question, please.
When is it okay to refer to surgery if we can't get a urologist?
Oh, that's a good question. You mean pediatric surgery? I would say that if you can't get a urologist, it's okay to refer to a pediatric surgeon anytime. Anytime, because a pediatric surgeon is going to be, there's a lot of cross training that goes in that's involved. And if the pediatric surgeon can't handle it, then he'll find a pediatric urologist. There, there's a lot of how shall I say this? Not conflict, but in most places, pediatric surgeons and urologists kind of divide the turf and they don't fight over turf a lot. But in some places, that's not the case. So in the case of Wilms tumors, a Wilms tumor, care of children with Wilms tumor can either be by a pediatric urologist or a pediatric surgeon. And sometimes they fight over that turf and sometimes they don't. Same can be said for undescended testes. Most pediatric surgeons are quite skilled at doing hernia repair in children. And basically an orchidopexy is a fancy way of doing a hernia repair, a little more involved, but most pediatric surgeons are quite capable of doing an orchidopexy in a child with an undescended testis. When would a pediatric surgeon not be comfortable doing? I don't know. If it involves a transurethral resection, like posturethral valves, that's most appropriately handled by a pediatric urologist as opposed to a pediatric surgeon. But there's a lot of overlap. So good question.
Next question. You mentioned that ambiguous genitalia is emergency. How do they determine how the surgery will proceed for which gender and what are the risks?
Very complicated question. I don't know how to answer this question, but it's a multidisciplinary, the team decides what the sex of rearing is going to be. And when they decide say they have a child with severe hypospadias and they decide that the best sex of rearing, and the severe hypospadias is XX female, and they decide that the best sex of rearing is going to be female, then the urologist and gynecologist will decide on how to create a vagina, and you have to retract the enlarged clitoris and make it a normal clitoris. But that's a really good question. Again, it's complicated and it's a team approach, and the surgery itself takes place according to their decision. But that would be one way of it. On the opposite end, if you decide that the child is going to be, say it's a severe hypospadias and the child is XY, then with bilateral undescended testes, then the urologist will decide when to do the hypospadias repair. It might be a staged hypospadias repair when it's severe hypospadias, which means that the child is going to require 2 operations for that, and another operation to bring both abdominal testes down into the scrotum. And that's usually before the kid is a year old. Does that answer that question?
I think so. This question is, I'm thinking, Are there many lawsuits for the intersex issues with late diagnosis?
Not to my knowledge, no. I think if there are any lawsuits, it should be against the politicians. Should sue the politicians, not the doctors. It's not usually delayed diagnosis of intersex is not the fault of anybody. It's the condition, like in testicular feminization. That child appears to be a female with 46 XY and no female internal organs. And that's because of what I spoke about. And the end organs are not sensitive to testosterone. So I don't think anybody could sue a doctor for delay in diagnosis for an intersex condition. And there's none that I can think, unless the genitalia are intersex at birth and nothing is done. I mean, if you ignore a child with severe hypospatus, or you just write it off as, oh, this kid is a male and has severe hypospatus, when in fact it turns out to be a female. But I don't really know of any lawsuits like that. I'm more familiar with lawsuits involving delay in diagnosis of prostate cancer. So if you want to talk about that, I can talk about that for hours.
That's true.
Yeah.
Next question. Are there complications with the duplicate bladders?
Oh, duplicate bladders are very, very rare thing. It's yeah, there are. You have to make one bladder out of a duplicate bladder. There's such a condition in the gynecology field, a duplicate uterus, and they have their way of dealing with that. I think they take one of them out. With a duplicate bladder, which I've never seen, I've only heard of it, you create one bladder out of the two. A duplicate ureter, um, there are some problems that go along with the duplicate ureter, but again, these are rare things and they're fixed on an individual basis.
Are there any updates on the role of VCUG in kids with pyelonephritis?
Pyelonephritis. Okay, the role of the VCUG in pyelonephritis is the question. Well, if you have a kid with pyelonephritis, they need a VCUG, period. Because you want to know whether or not that pyelonephritis is caused by reflux. There's nothing new in that regard. Even if they don't have hydronephrosis, if they have pyelonephritis, particularly if it's febrile pyelonephritis, if it's just a urinary tract infection, first time urinary tract infection in a female, no need for a VCUG. Recurrent urinary tract, first time urinary tract infection in a male, that little boy needs a VCUG. Recurrent urinary tract infection in male or female, they need a VCUG. So then nothing has changed as far as that goes. What it has changed is that when you're following, and this is not really a change, but if you're following a kid with recurrent urinary tract infections and reflux, and you're waiting to see if the reflux is going to resolve or it is resolved, the follow-up, you don't do a follow-up VCUG, you do a nuclear medicine cystogram. And the nuclear medicine cystogram has a lot less radiation exposure to the child. Or say you have a kid with meningomyelocele that's been repaired, and that kid has a neurogenic bladder that refluxes, and they're getting better on medication, and you want to see whether or not they're still refluxing. Then you do a nuclear medicine study, not a VCUG.
Wonderful. Next question. A young female with recurrent UTI and unable to cath should have referral to urology or gynecology?
Unable to cath?
Yes.
Why?
Martin,
Why?
if you
Why are you unable to cath? First of all, I don't think a child should need to be cathed in this day and age when you're evaluating a child with recurrent urinary tract infection. If you're trying to decide whether or not the urine is contaminated or if the genitalia are not normal, and that's why you're having trouble cathing the kid. All right, first of all, let's talk about recurrent urinary tract infections in girls. Okay. Or let's talk about urinary tract infections, period, in anybody. If the specimen is contaminated and you think you need to cath them, it's either a problem of poor preparation for obtaining a clean catch midstream urine, or the genitalia are not normal, and that's why you can't see the urethral meatus when you're trying to cath them. If you can see the urethral meatus, there should be no problem cathing a kid. If you see the urethral meatus and you can't get the catheter in, then that kid needs to be referred to a urologist.
All right, so there's some follow-up that said could not find the opening. She was not potty trained.
I don't recurrent full-blown urinary tract infections. I mean, febrile urinary tract infections, recurrent febrile urinary tract infections.
Oh, wait. And then somebody else, oh, she said 2.
2 urinary tract. How old is the child?
Would it be helpful, Margie, if I unmute you? About 3. She's about 3.
She's 3.
Yeah.
Were the infections febrile or not febrile?
Margie, I'm going to give you the ability to unmute yourself. So you should be able to, so we can do it this way.
Yes, I think can you hear me?
Yes. Hi, Margie.
Okay, hi. Thank you for this talk. It's great. From what I remember, she was not febrile, but it was her second time coming in with UTI symptoms.
I see.
The first time, I feel like it was definite, and the second time possible. I just thought of her with the talk. So I think for sure it was one definitely documented and possibly a second one. I do not remember her being febrile.
Has she had an ultrasound of her kidneys and post-void bladder?
No, not that I remember. And she wasn't one of my patients, and I think I saw her one time, so I'm going to investigate and find her.
Okay. I would not cath her. It's
Okay.
not necessary. I would examine her, and if she has labial fusion, and that's why you can't see the urethral meatus, then that child should be referred to a urologist. If you can see the meatus, I still would not cath her if she's urinating with a good stream. And if her ultrasound post-void residual is 0 or less than 10 cc's. So in that situation, there would be no need for a pediatrician to catheterize a child if the exam is normal. If the exam is not normal, or if the residual is high, then that child should be referred to a urologist. You're
Thank
not
you.
going to be able to, if you can't cath, you're not going to be able to do a VCUG anyway. And a female with 2 urinary tract infections should probably have a VCUG and a referral. Does that help answer your question?
Yes, it does. Thank you.
I also think this is an excellent reminder type of case that if you have these type of questions in your practice, you can always submit a e-consult on our platform directly to Dr. Lieberman, and he'd be able to help walk you through that, or any challenging case for that matter.
There are actually 2 of us that do pediatric urology. Adrian Carmack does pediatric urology, and I do pediatric urology. So, and we love questions. We love consults. When I don't get a MAVEN consult, I feel like my day is not complete. So send them on. We love doing them. Never hesitate to send a consult, please.
Yeah,
Thank you.
I do. I always tell everyone that our volunteers are waiting for them. So please feel free. And if
That's
you
right.
think of a
And many of
question,
us have such severe OCD, we're checking our email like times a day. So
fair. All right. Well, I don't see any more questions. and we're almost at the top of the hour, so we have 1 minute left. We'll pause. If you have any last minute questions, please feel free to type them in or use the raise hand feature. Just a reminder that the slide deck and the CME survey link will be sent tomorrow, about 24 hours from now, and for your review. Also, the CME survey link will appear in your tab, on a tab on your browser when you close out of this webinar. If you have any questions after this, you think of a great question afterwards, you can use the e-consult, or for any of your, patients with urology. We also do offer specialty-specific mentoring. So if you think that this is something that you would really like to spend several weeks discussing, you can always complete a mentor request for this. But I don't see any other questions, so we'll
I
end
have
it
one
now.
more comment.
Oh, yeah.
Don't buy my books because Jill Einstein and I have applied for a grant through the Urology Foundation of the AUA to provide every MAVEN clinic that MAVEN serves, which is over 400 of them across the United States, every MAVEN clinic a copy of each book. So we're waiting to hear whether or not the grant is accepted. So
Wonderful.
don't buy the book until if we get the grant, we'll be sending you a copy of each book to each clinic.
That's exciting.
Yeah.
All right. Well, thank you all for joining us today. Dr. Lieberman, thank you so much for presenting.
Thanks for listening. Thanks, Kristen.